Just tell me when you want me to start.
Yes, the recording has started, so it's all on you now.
Okay, great. Well, hello, good afternoon, everyone. I'm very happy to be here to speak with you today. My name is Cynthia Gonzalez, and I'm an advanced practice nurse and orthopedic clinical nurse specialist. I'm currently completing my PhD in nursing, and I'm actually studying osteoporosis prevention in early menopausal Latina women. So my presentation today is going to be on osteoporosis prevention through early detection. And if you have any questions, please feel free to ask. So just a reminder, time is ticking on bone health. Many people don't realize that bone health is something that needs to be evaluated and looked at from early age to late adulthood. So osteoporosis is actually a weakening of the bone. The bone is made of cortical and trabecular bone, and I'll show you a picture in just a second. And what happens is, as we get older, we tend to stop doing as much weight-bearing exercises because we're seated at desks, or we just don't get up and move or exercise as much. Compound that with other issues such as the pandemic, where people really couldn't get out. That adds to a decrease in bone density. So what happens first is osteopenia, and osteopenia is actually loss of bone. So the thickening bone that you had growing up starts to get less and less as we get older. And actually osteoporosis is known as the silent thief because people don't realize that they have weakened bone until all of a sudden they have a fracture. So osteoporosis is weakening and porous bone, and it is measured through bone density scans. And so what you would see is a decrease in bone density. And as I said, many times osteoporosis is evaluated once a patient fractures. So how is bone built? So bone building actually begins, when in utero. So when your mother's pregnant, and so your bone with very pliable bones, and the bones actually in the skull override each other so that your mother can give birth, and then those get hardened, and your bone is very soft when you're born, and it hardens as we get older. And then peak bone mass is actually achieved in the third decade of life. So in your 30s is when you hit your peak bone mass. And usually, by that time, people have been very active. They've been playing sports, doing other things that help with that bone mass. As we get older, though, in our 30s, what happens? We start working. We don't have as much time to go to the gym. We don't have time to do other exercises. And so bone starts to weaken somewhat. So as I stated, bone is measured through bone mineral density scans, and those can be done at any age if needed, but insurance tends to not want to pay for that until, if you're a woman, you're postmenopausal, or if you're a man, you're usually in your 60s. And bone mineral density scans report scores known as T and Z scores. And in women, the T score measures the postmenopausal woman's bone mineral density compared to an average healthy young woman. And then T scores are also measured in men, and they just tend to be looked at via age and actual like BMI, body mass index. But men tend to be neglected in many osteoporosis studies. So how does the fracture occur? So here on the left, you'll see normal bone. So it actually looks like a sponge. So and the bone is actually spongy or cancellous bone is what it's called. And these little holes here are called trabeculae. And what happens is, as we lose bone density, that those like little bridges of bone start to get weak. And you'll see here in the osteoporotic bone, it's diminished or gone in many areas. Or here you'll see this fine line here. I'm not sure if you can see my pointer, but right there is an actual fracture. So as this gets weak, and you'll see most osteoporotic fractures are in the spine or in the hip. And patients will tell you, I was walking and I fell, and they didn't really fall. What happened was the bone was so weak that their normal body weight caused them to fracture. And so when they fractured, they actually fell. Now, subsequent to osteoporotic fractures is something called a fragility fracture. So if you've had an initial osteoporotic fracture, you should really be evaluated with a bone mineral density scan in order to ensure that you do not develop additional fractures. So fragility fractures are most associated with weakened bone. And fragility fractures can happen after a simple fall or an accident, and they are preventable. So I'll give you an example. I had a patient, he fell out of a chair, and he was 85 years old. And when he fell out of the chair, he was having hip pain. And so I got called to see the patient, and I said, can you walk? And they're like, no. And I said, put your legs out. And immediately I could tell he had a hip fracture, because the most common sign of a hip fracture is a shortened leg, and it rotates outwards or externally rotates. And so we were able to take the patient to the hospital. He ended up having a hip pinning. But subsequent to that, the patient was also a dialysis patient. So he had end-stage renal disease. And kidney function has a lot to do with parathyroid hormone and vitamin D synthesis. I'm sorry. And so what happened was his bones were already weak, even though his nephrologist said, we're checking his labs, everything's okay. So patient went home and was walking down the stairs and literally stubbed their toe and said, I think I did something. And the family member looked at the leg, and there was nothing there. They tried to stand the patient up again and walk them down the rest of the stairs. The patient couldn't walk, and they had to call the 911. They took the patient to the emergency room, and the patient had a fracture of the tibia, which is the lower bone in the leg, and it was an osteoporotic fracture. So probably had the hip fracture from the fall, which was traumatic, but also due to osteoporosis. And then because of other underlying diseases like the renal failure, he was osteoporotic. So just stubbing the toe caused that other bone to break. So that was a secondary fracture or a fragility fracture. And again, these are preventable if the physician or healthcare team identifies that they need something in order to enhance that bone stock. So there are two types of osteoporosis. There's primary and secondary. And primary, it has two main types, juvenile and postmenopausal. So juvenile osteoporosis is caused by alterations in tissue. And a main diagnosis, to work with a child, and they said, oh, this child has osteogenesis imperfecta. It just means that the bone cells that proliferate to cause bones to be strong are decreased, and the cells that cause bone to be weak are increased. And other diseases such as leukemia, chronic inflammatory diseases, prolonged immobility. Sometimes patients who have cerebral palsy or muscular dystrophy and they're immobile, they will get weakened bones. And any use of medication such as anti-epileptics or glucocorticoids can also cause juvenile osteoporosis. And then that moves forward into adulthood. A positive diagnosis of juvenile osteoporosis can also be made based on a history of a vertebral fragility fracture by the age of 10 or any long bone fracture by the age of 19. And long bones are like the upper leg bone, which is the femur, the lower leg bone, which is the tibia, or the upper arm, which is the humerus, or the lower arm, which is the radius or the ulna. So if you see any like ulnar fracture, radial fracture, anything like that, you'd be concerned about juvenile osteoporosis, especially if they have underlying issues. In adulthood, postmenopausal osteoporosis is the most frequent type of primary osteoporosis. And by postmenopausal, I mean someone who's been in menopause for at least one, or has been without like a menstrual period for 1 year is considered menopausal. So postmenopausal is someone who's already past that time. And so you have hormonal changes associated with menopause, mainly the decrease in estrogen. And so that decrease in estrogen then means that bone reabsorption occurs more rapidly than bone formation. So then that weakens the bone. And a lot of women are like, oh, I exercise, I swim all day, like 5 days a week. Well, swimming is not considered weight bearing because you're buoyant in the water. So if they say I swim 2 days a week and then I do, heavy aerobics 3 days a week, then those days that they're doing aerobics are days where they're doing, actual weight bearing exercises. But also you need to know that heredity has a lot to do with bone density also. So I'll give you myself as an example. I'm a 2nd degree black belt in Taekwondo. I jump, I kick, I punch, I do all kinds of stuff. I've been doing it for 10 years. And I'm postmenopausal, and I asked my doctor for a bone density as I was leading up to my research. And I found out I've already lost 1/2 inch and I have osteoporosis in my spine. And not even osteopenia, it's osteoporosis. So I've had to start taking medication to help decrease my bone from getting even weaker, because I want to prevent a compression fracture, which is the type of fracture that happens in the spine. And I don't have any other history other than my mother was the same age I am now when she was diagnosed with osteoporosis. So familial history also has a lot to do with it. But finding out that you have a osteoporosis diagnosis is very important to prevent the debilitating issues associated with fractures. So bone weakness also leads to, as I said, vertebral fractures, or if I were to fall on an outstretched arm, you could fracture your radius. So secondary osteoporosis is defined as either glucocorticoid induced or organ transplant induced or drug induced. And by glucocorticoids are medications like steroids that are often given for certain diseases, such as Cushing syndrome is a disease of the pituitary, or they're given for autoimmune or inflammatory disease treatments. And so autoimmune issues can be like rheumatoid arthritis. It can be multiple sclerosis is considered autoimmune, like Sjogren's syndrome, some other syndromes that you might see that are inflammatory or autoimmune. Those diseases are treated often with corticosteroids or glucocorticoids. And so glucocorticoids actually cause bone weakness because, again, there's that proliferation of osteoblasts, which break down bone faster than osteoclasts, which build up bone. Also, patients that are on or have had organ transplants oftentimes develop osteoporosis because the immunosuppressive medications that they take are very high in cortisone, and cortisone has a direct negative effect on bone. So you'll see oftentimes, even like with COVID, everyone's like, oh, put them on anti, they were putting them on anticoagulants, some of them were being placed, patients were being put on antibiotics. And then I worked with a nurse practitioner who was putting everybody on prednisone. And I'm like, why are you putting them on prednisone? She's like, oh, it'll help them with their breathing. And I said, yeah, but it has a direct effect on their bone formation. So we were always like, okay, patient needs to breathe. That's obviously the priority, but the patient's breathing okay, then don't give them prednisone unless there's a reason for it. And I'm always very conscious of use of any kind of like glucocorticoid type medication or steroid, because it can affect the bone negatively. And you'll see a lot of children who have severe asthma use steroid inhalers all the time. And I'm lucky I have a niece who's a pharmacist. So I had a student once who asked me, is that going to affect my child's bone? And we figured out that if it's just used in normal dosing, it should be okay. But those are some questions that sometimes people have. So the cost of osteoporosis is increasing. So according to the 2010 census, if you're looking just at the Latino population, which was 35.3 million in the year 2000, it's grown over 43% throughout that decade. and 33.3 million Latinos were ages 18 and older. And in the US, the prevalence estimates show that 10% of Latino women over age 50, or approximately 400,000 women, are likely to have osteoporosis, and 2 million are experiencing low bone mass. Healthcare costs amongst just US Latino women are predicted to increase by 175%, and that's between 2005 and 2025. So we're just 2 years away from that. And most costs related to osteoporosis are due to fracture care. So as I said, the most common types of fractures tend to be hip fractures. In hip fractures, the only way to really heal them is to perform a surgical intervention, which is usually either hip pinning, or if they have severe arthritis associated with them, then they would do a total joint replacement in the hip area. So again, risk factors, as I said, DEXA scan or bone scan will help in predicting it. But in women, significant risk factors include a previous fragility fracture, which again was a secondary type of fracture, maternal history of osteoporotic fracture at 75 years of age or less. So I said my mom was osteoporotic, and she had her first fracture in her 40s. And it was a traumatic fracture, but if it had been further evaluated, they might have found that she had osteoporosis at an earlier age. Then also early onset of menopause, which is before age of 45. And if you look at the data in Latino women, most women tend to start, if they're going to have early menopause, they start at about between age 45 and 47. And if you break it down by specific like country, Mexican women tend to start at about like age 45.2. And then bone mass index, which is the measurement of bone, body mass index, which is your height and weight proportion, if it's greater than 19 kilograms per meter squared. And then also prolonged glucocorticoid use. And something I learned when I was doing my studies is loss of calcium during pregnancy can also be an indicator of primary osteoporosis. And if you think about certain areas of Latin America, there are women that have many more children than in other areas. So those women may be at a higher risk because of breastfeeding. Okay, so as far as prevention, as I said, DEXA scans can help in preventing fractures, and a DEXA scan and a bone mineral density scan are the same thing. Failure to prevent osteoporosis can contribute to immobility and then subsequent comorbidities such as cardiovascular disease and diabetes. So we know that the Latino diet, unfortunately, is very prevalent in carbohydrates. And so that leads us to, if you're at high risk for diabetes, it kind of tends to push you towards becoming diabetic. And then that can lead to cardiovascular disease. And so, add to that a fracture where you're immobile, that's just going to worsen some of those other issues. And 95% of fractures in patients older than 75 years who are hospitalized, and 89% of those patients between 60 to 64 can be attributed to osteoporosis. Therefore, screening is a priority in prevention. So how does osteoporosis affect the Hispanic community? Well, many times Hispanics don't go to the doctor until they're like so sick and everything they've tried at home isn't helping. So we already have limited healthcare access or language barriers. Many times, I saw it in my parents and in my grandparents when I was younger. They didn't know English very well, so they only went to doctors from our country, and I'm from Bolivia, so you can see there's not that many Bolivian doctors. So it made it difficult to obtain knowledge regarding osteoporosis prevention, and the doctors that they saw didn't know a lot about osteoporosis either. Again, it's a silent disease and it's not seen, so it's not until you actually fracture something that you realize something might happen. Even when you do fracture, oftentimes they don't screen for osteoporosis. And of the limited studies that are available on Latino women particularly, most data on bone fractures and risks for osteoporosis were in like the southwestern part of the United States from women of Mexican descent. And there was one study in Boston that was mainly on Puerto Rican women. So other countries weren't really prevalent in some of these studies, at least the ones done in the United States. Latino women not only share risk factors for low bone mineral density with other ethnicities, but also cultural, psychosocial, biological differences need to be considered for treatment and prevention. In fact, most of the studies that you'll find are on Caucasian women, and it was felt that Caucasian women and Latino women have the same bone mineral density. And as they started looking more in depth, they found that we don't have the same bone mineral density as Caucasian women. Ours tends to be a little bit stronger, but if we have other risk factors, then we kind of follow the same trend. And African American women actually have the strongest bone density. So fracture liaison services, this is a group that evaluates patients upon admission for a fracture. And it's something that began back in the early 2000s. And so these were nurse practitioners or advanced practice nurses or physician assistants who should be evaluating a patient when they come in for a fracture to evaluate whether or not the patient had a previous fracture. And if they did, then the patient should be referred to an endocrinologist or an internal medicine with information about follow-up for this patient so that once the fracture heals, they can see, is this patient at risk for future fractures? So that's one way of helping to diminish osteoporosis. And then I just wanted to talk about osteoporosis as a healthcare issue. So in 2017, the American College of Physicians actually recommended that women, postmenopausal women in particular, that are evaluated with a bone mineral density test and are found to be osteopenic, be treated with oral medications. They're called risdipyrates, and that type of medication would be something they would take for 5 years and then reevaluate after 5 years to see if the bone mineral density changed. And usually it does, it gets better. And so then they can evaluate whether they continue on it and just monitor or what the next step would be. So now there's also medications that are given via injection once a month, which is that Prolia or denosumab, which you might see some commercials for that on TV. And that tends to be for older women that may not be able to tolerate some of the oral medication. Oral medications have to be taken with a full glass of water in the morning without any food, and you have to stay upright because the medications can also cause a lot of gastrointestinal issues. So some patients may not tolerate that well, so that's why they would go to injectables. But also the Grain of America, back in like the 1990s, actually University of Illinois Chicago did a paper on the Grain of America, and it showed all the issues that were going to happen as baby boomers became older adults. And so we're kind of in that period now where we're starting to have the Grain of America. So the government really needed to increase the amount of services for older adults. So especially, in the wake of these baby boomers aging. So one of those would be to increase osteoporosis testing for patients. So let me see. And then, as I said, the financial burden of osteoporosis is predicted to be $17 to $20 billion. These patients have surgery and they have to be in the hospital at least 3 days, although now they're really trying to push people out the door after like a day. And they're not doing general anesthesia anymore. They're doing blocks so that the patients can get up and get moving. They get them up and moving sometimes in the recovery room, and then keep them overnight and try to send them to a rehab or someplace where they're not actually in the hospital. There was an 11.5% risk of increased fractures that was predicted by 2020, and most of those fractures were in older adults. And in patients that are over age 80, the prevalence of mortality is 80% or 50% within 6 months. So I'll give you an example. Both my parents had hip fractures. They're both now have passed away. My father died within 6 months of his hip fracture because he needed a secondary surgery and he never recovered. My mom had lived for 4 years after hers and then died from something else. But you know, I always had that in the back of my mind when they had their fractures was, oh my gosh, how is this going to work out? And so they went both ways. So one passed away within 6 months of their fracture and the other one lived past 4 years. So it's all, again, depends on secondary issues that they might have too. So a current policy issue, there was an act that was put in front of Congress in 2019. That was the increasing access to osteoporosis testing for Medicare beneficiaries. And the last I knew, it was introduced. I don't know if it's been killed in Congress yet or not. I need to do some more follow-up, but it was an amendment to the Social Security Act. And so it was to improve access to and utilization of bone mass measurement benefits, and it would be under Part B of Medicare. And it would establish a minimum payment to provide for bone mass measurement. And if you think about, they dropped the age of women getting a mammogram, and they dropped the age of everyone getting a colonoscopy, and all of those are preventative. So they should be dropping the age of when someone can get a bone mineral density test and have it paid for. So that's what the policy issue is in regards to. And so as far as funding, the Social Security Act would establish regulations for Medicare. So that still only goes to age 65. So we would need something that would kind of lower the age so that people under the age of 65 could have this paid for by insurance. But usually if Medicare approves it, a lot of times the other insurance companies would follow suit. But again, this would need to be approved by Congress and the Committee on Finance in Congress. So stakeholders that would benefit, obviously, from these changes would be the populations that have potential bone loss. So osteopenic patients, those who are taking steroids for other comorbidities, patients who might have hyperparathyroidism, which affects, their load of parathyroid hormone and vitamin D. And then people who have calcium deficits, because you need calcium in order to be able to upload or uptake vitamin D as well. Patients who are immobile. So oftentimes patients who've had spinal cord injuries, you see how their muscle wastes down, their bone also wastes down. So, when you see these like wheelchair athletes and stuff, I'm always worried if they have an accident, are they going to have a fracture because their bones are not very strong. Nurses, especially advanced practice nurses, would benefit because they could identify people at an earlier time that may be at high risk for a fracture. Physicians, orthopedic surgeons wouldn't have to be doing, I don't know how they would benefit other than the fact that they would not be doing as much surgery on some of these fractures, but at least they could help with identification and treating these patients. Internal medicine physicians and endocrinologists would work side by side, identifying these patients and treating them also at an earlier time. Additional stakeholders would be insurance companies, because they'd have decreased claims if fractures could be prevented, and patients would have less pain, less immobility, less needs for rehab, less need for inpatient stay, less need for surgery. It all works out really well if you can identify a fracture at an earlier time. And then pharmaceutical companies would benefit because we're increasing the use of medications that increase bone density, and then hopefully decreasing the use of other medications that cause osteoporosis. And the literature does show increased rates of mortality from fractures. As I stated, patients over age 80 have a mortality rate of death within 6 months. And so the prevention really is key to decreasing the incidence of these fractures. So increasing funding, if possible, is important. And the current government support for osteoporosis, or for a lot of the elder type of diseases, fall underneath the United States Prevention Task Force, Healthy People 2030. There is a chronic disease self-management education program and the Joint Commission. And I've worked with the Joint Commission looking at advanced certification for like total hip and total knee replacement patients. They don't really look at osteoporosis as a reason for needing a total hip more likely than a total knee. They look more at like osteoarthritis or rheumatoid arthritis as being causes for those. But we really need to look at overall at the patient. If you have a patient that has osteoporosis, also their bone may not tolerate some of the hardware that you need to use for fixation. So they tend to use a lot of cement, and if the patient were to fall by accident, they could fracture below the actual component, and that would cause more issues and more problems with immobility. And in certain like third world countries, they can do the joint replacement. But again, if something happens and there's another like traumatic injury, that patient may end up immobile for the rest of their life. And I know I've seen that in family friends who were, my family's again from Bolivia. They were in Bolivia, they fell and broke their hip. And they did a joint replacement there, and she came back home and she's mobile, but you can tell she has a leg length discrepancy because they did not measure the leg correctly when they did the joint replacement. So there are a lot of differences sometimes in the way care is given in other countries. So possible solution is continued funding for bone mass measurement, increased education. There's the International Osteoporosis Foundation as well as the National Osteoporosis Foundation that provides education. If I was going to see you in person, I had handouts for you, but I can share like the email addresses for you. They have information both in Spanish and in English available. And the American Association of Orthopedic Surgeons also has a program called Fit to a T, and that was originally set up to educate men about osteoporosis. And I've given several lectures in both English and Spanish to different people about what that means. So we need to practice what we preach. We need to support bone health. And the way we'll support that is through weight-bearing exercises, healthy diets, high in protein, high in calcium and vitamin D, and then making sure that patients are provided access to baseline bone density tests. And that's it. Do you have any questions? Stop sharing here.
I have a question.
Uh-huh.
You said that at the age from 45 to 47, most likely we should get a test done to check for osteoporosis. Do you have to have a history in the family, or would the insurance cover for that?
If you are a postmenopausal woman and you have a family history, then you would have to, I would speak with your insurance company and make sure that they would cover it. I had mine done at like 53, I believe, 53 or 52, I can't remember, and it was covered. And they didn't ask why. My doctor just put on the order that I was already menopausal and that there was a family history of osteoporosis, and they covered it without a problem. So it's how your doctor writes the order, but I would always double check with your insurance company. But again, you want it done at a younger age if you are already if you've had early menopause. Uh-huh. Any other questions? I don't know if there's any. I'm trying to see if there's anything in the chat.
I have another question.
Yes.
What over-the-counter vitamins would you recommend?
Calcium with vitamin D. I believe you're supposed to have 1,200 milligrams of calcium per day, and it should have vitamin D associated with it. Now they're really big pills. If you like, I don't like to take pills more than once a day, so I get the really big pill, but you can get them smaller, and then you would take them twice a day. But calcium with vitamin D is usually the first line that you'd want to do. And think about where we live. You know, we live in the Midwest, and so we don't go out much. Like it's crazy now that it's so nice and and it's April, and it's sunny, and everyone's wearing shorts. And you know, I'm a teacher at university level, and all the students are like wearing all their like summer stuff already, and I'm like, wow, amazing. But if you were to have a vitamin D level drawn, you might find that your vitamin D level is low because we work inside and we're not outside often. Plus, if we're a little bit darker skinned, it takes a longer time for us to absorb vitamin D through our skin. So you get vitamin D from the sun rays also. So if you're outside a lot, that's great. You can tell people you're getting your vitamin D therapy. But for the most part, we tend to not absorb as much vitamin D as others, because we're a little bit darker skinned and we're not outside as much. I hope that answered your question.
And what if, I'm sorry, I have a question.
Yeah.
What if you have a hard time taking calcium pills?
You can try
because
to
you
get it through your
feel,
diet.
I mean, would it be just as good or
Yeah,
less
you can try to get it
effective?
through your diet, or you can ask the pharmacist if there's anything else you can take, like a chewable. You know, everything's coming out in like gummies now. So you can see if there's something chewable. I know before I started having to take calcium, I had just the chewable multivitamins, and those had vitamin D in them. And so I just took 2 a day, and that worked out well.
Can you
But if
repeat
you're
how
ever in
much
doubt, talk to the
calcium you
pharmacist.
recommend?
Oh, I don't know any specific brands. I tend to go generic because the costs are so high. I tend to go generic. I actually go to Costco. I get the huge bottle of the gummies, and I use those. I use the multivitamin, and then I take a calcium on the side.
But how much of a dosage of calcium in terms of units, or you said 12?
I believe it's
1200?
1,200 units. Let me double check here. Of course, I can't get it to work. I want to say 1,200 a day.
Okay. Thank
But
you.
remember, if you're getting it in your diet also, you might not need as much. So you're going to get it in your diet with like milk, some juices, you know, that have calcium supplements in them, because you don't want to overdo it either.
Okay.
You can get it in milk, cheese. Let's see, depending on your age. So if you're a female between 19 and 50, you should take 1,000 milligrams. I'm 55, so that's why I was saying 1,200. 51 through 70, it's 1,200 milligrams.
How do you know you have too much calcium on you?
If you're hypercalcemic, you tend to have your muscles start to, it's called tetany. So your muscles tend to quiver a little bit. And then if like you touch your face, it'll twitch. That's called a Schwastek sign. So you'll see that if you have too much calcium.
Okay.
But if you average about 1,000 milligrams a day, you should be fine.
You.
But remember, vitamin D is really good, and vitamin D helps you absorb the calcium. Any other thoughts? I hope this was helpful or gave you some more information than you had before. Oh, you're welcome.
You have a class now?
No.
Hi,
Okay.
Cynthia. I think that's it. Thank you so much. It was a
Okay.
great presentation.
Okay, thanks.
We
I hope
really
it was
appreciate
long
your
enough.
time. Oh no, it was perfect. Everything was great. Thank you so
Okay,
much.
great. All right, well, thank you. I appreciate it. If you guys have any other questions in the future, just let me know if anyone has questions they didn't ask. You know my email, so.
Yes,
feel
I have
free
your
to
information, definitely.
Okay,
We'll keep in
Great.
touch. Thank you so much.
all right. Thank
You have a
you.
good
Take
rest
care.
of your week. Thank you.
Thank you. You too. Bye-bye.